Well, thank you very much for inviting me to have this speech and talk for the PCSI 2022. And my regards to all of my friends in India and all over the world. I was asked to speak about the stenting of the native RVOT. As you may know, it's something that we use right now because of the as a form of palliation. Taking the time, I go into my talk. I have no disclosure. And as an introduction, you may know that the single stage repair for tetralogy followed in some kind of congenital heart disease with cyanosis sometimes needs some kind of palliation, and sometimes there's not enough time for doing these total corrections. Anyway, it remains an important subgroup of high-risk patients all the time with small PA branches in tetralogy followed or some complex congenital anomalies that we may need the stage repair. It means an initial palliative procedure and followed by definitive elective repair, which may still be indicated due to high risk of the mortality. So the patients can firstly divided into main groups. Those neonates with small or a small infant with small pulmonary arteries, they may be tetralogy followed, for example, as this picture. As you can see, RP and LP are very small, and this is the tetralogy followed. And there may be some complex anatomies and some other variants of scene that may be have a high risk single stage repair. So as you can see in this picture, it's a very complicated patient and with very small PA branches and very small native pulmonary artery. So in this kind of patient, the single stage is not possible for most of the time. So when we use a stage approach, the ideal management, as you may know, is the single stage, but as there are some groups that we have very high risk operations at that time, for example, very small PA branches, every time the single stage or palliative stage is always a debateful among the cardiologists and cardiosurgeons, but particularly when there is an urgent or emergency situation, for example, cyanosis and spells, we have to go for stage procedures. Well, historically, the blood oxygen shunt was considered the management for the patient for tetralogy followed, but in the current era, primary repair of tetralogy follow is preferred, as many institutions and some of them do the first stage and for the total complete cardiac surgery. But there are some institutions that still goes for systemic to pulmonary artery shunts, and because of the equipment and because of the facilities of that center. This is a very historical and very important picture from Johns Hopkins that a few years ago they celebrate the 75 years since the historic blue baby operation in this hospital. And that time these guys, Alfred Blalock and Vivian Thomas and Helen Tosin, was those persons that did the first operation for the blue babies, those cyanotic patients that had the blood-tossing shunts for the first time. The classic the versus the modified blood-tossing shunt is shown in this picture, and the classic form, the left subclavian or sometimes right subclavian artery was divided, and it was anastomosis to the left pulmonary artery. But right now we use the right subclavian artery connecting to the right pulmonary artery with a patch of Gore-Tex and tube of Gore-Tex. This is the artificial synthetic particle that we use for these connections, and this is called the modified blood dosing. Anyway, the arterial shunts, like blood dosing, has many benefits. It may stabilize the clinical condition and improving the PA flow and allow to elective repair in the future. But there are some significant incidences and sudden deaths among these patients, and autopsy proved that there are some thrombosis among these patients, and it caused the sudden deaths for this kind of patient. And furthermore, inappropriate surgical techniques may lead to pulmonary artery distortion or stenosis at the site of the shunt to pulmonary artery anastomosis. As you can see in this patient, it's a 4-year-old patient in our clinic. That, as you can see, the blood dosing shunt has been performed a few years ago, and right now you can see a very stenotic part on LPA and the bifurcation, and it is very, very complicated. So it is done with the technical form of the anastomosis between the cortex and also the LPA at the site of anastomosis. So we decide in the new era to use the RVOT stenting. If we have to use some palliation for those neonates which has that we want to have more flow to the pulmonary artery, we can insert the right ventricular outflow tract, it means RVOT, as an alternative strategy to secure the pulmonary blood flow using a stent in the RVOT. This is, for example, a patient with 6 months old, 6 kilogram tetralogy followed, and small PA branches. As you can see, there is very small RVOT and very stenotic RVOT, and you can see that it is very narrow RVOT and also PA branches. So we, in this technique, we insert some wires. Most of them are coronary wires passing through the very small RVOT to the pulmonary branches, and we also do this. As you can see, we pass a stent here. This stent is a kind of renal stent and sometimes coronary stents for the peripheral vessels. And you can see here, oh, excuse me. Yes, by finding the landing zone for a good place of the stent, we can inflate the stent, and after that you can see that we have a good flow through the pulmonary arteries. The pulmonary arteries are a very good size, but there was a very stenotic RVOT that was preventing from the blood flow to the pulmonary arteries. So in another example, that when the baby is very small, as in this example, is an 8-day-old boy with 1.8 kilogram tetralogy followed. It's nearly pulmonary atresia. It means external tetralogy followed. As you can see that the RVOT is nearly closed, but we can pass another coronary wire inside, and after passing, we use a predilation with a coronary balloon size, for example, in this patient, size number 3, in diameter 3 millimeter, and after that, inserting a stent among the RVOT near the pulmonary valve, and after inflating it in a very good place, we have a very good palliation and a very good flow through the pulmonary arteries, and we can use this RVOT stenting as a palliation, very useful and most of the time. But every time the procedure is not so simple. For example, at this 5 days old neonate with cyanosis with the weight up 2.8 kilogram, and SpO2 at the room air was 67%, and on chest X-ray we had markedly decreased pulmonary vascular marking, and the anatomy was again extreme tetralogy followed with very small PA branches. As you can see, by injection through the RV, we can see nothing passing through the RVOT to the pulmonary arteries. But we have some opacification of the pulmonary artery, but this opacification is not from the RVOT itself. It is from the MAPCOs, multiple MAPCOs, as you can see here. There are some MAPCOs from the side of the aorta to the left and right lung. And in this picture, you can see it's more clearly that we have also native pulmonary arteries opacification of the injection in the aortic descending aorta. That it means that we have some connections between the MAPCOs and the native pulmonary arteries. And when we look at this opacification through the lateral projection, you can see that we also see the main pulmonary artery opacification, but the pulmonary valve is nearly aphasia, so we have no inflow from the RV into that. So, as you can see in this picture, we can also go through some of these MAPCOs, and by injection through the selective injection through these MAPCOs, we can see in the right and the left. And when we go through the left injection by the MAPCO, we can see the native pulmonary artery. That it means that native pulmonary artery is connected to these MAPCOs. So because of that, we can go by inserting a wire through these MAPCOs through the main pulmonary artery, and by crossing that, we can pass to the RV. And this is what we have done for this patient. So after that, excuse me. Yes. In this picture, I have crossed from the descending aorta into the MAPCO, into the left lung, into the LPA, into the main PA, and into the RV, and we finally passed the wire into the RA and to the SVC. And by crossing it, we can snare it through the SVC, as we can do it here. Excuse me, something wrong with my computer. I don't know what's this. Yeah. And by making an AV loop, right now, we can go through the femoral vein into the RV again, and by crossing the RVOT and also the pulmonary valve in this case, we insert a stent in the RVOT retrogradely, and by inflating it, in this picture, we have good flow through the RV to RVOT and also to main pulmonary artery. And right now, we have a flow through the RV to the native pulmonary arteries. So this was a complicated case that we retrogradely passed through the MAPCOs to the male PA and to the main PA, and also we snare it out from the femoral vein, and after that we go classically through the RVOT and insert an RVOT stent through that. So RVOT stent advantages is some very important point. It is less invasive, less post-operative hospital stay, safer in small infants with low weight and hypoplastic pulmonary arteries, and less complications of PA branches stenosis or overflow. And RVOT stent is an option for tetralogy Apollo with pulmonary atresia also. But there are some risks for the RVOT stenting. We know that RVOT stenting may potentially benefits in terms of stabilizing the clinical condition and improving PA flow. I'm so sorry. And it's allowing for elective repair in future. But using the stent is always a very something awful for the surgeons. So you have to know about the subsequent repair and keep in mind that if you have to do that, pay attention to not go through the valve. So the surgeon have to go for transannular incision in that cases. So it is very important to do something that after, for example, 2 or 3 months, when the surgeon go for the operation, it has no problem with this. Also, it may be sometimes in this. In conclusion, successful stent implantation into the RVOT in patients with tetralogy Apollo and some complex anomalies with severe pulmonary stenosis and hypoplasia pulmonary artery is feasible, is safe. And in this technique, it improves the clinical condition, increases the pulmonary blood flow, and leads to an improvement in pulmonary artery development before the surgical treatment. And so I think that it is a good idea to go through the RVOT stenting in some selected patients and not all the patients. And it should be very, in skilled hands, it may be had many benefits to the patient. Thank you for your attention, and thank you for inviting me again to the PCSI in India. Thank you.